pleasure to welcome you here on campus, but also those who join us online for the lecture today. And it is, in fact, the second time that we host the Virchow lecture here at ESMT. As we were just saying, a German proverb says, once you do something for a third time, it becomes a tradition. So this means we have to wait for one more year, and we have to do it one more year so that we can really talk about a tradition. And it's a great occasion to celebrate science and leadership that transform lives. This is really what this is about. And it's, of course, a particular great honor and delight for me to welcome the two distinguished guests who won who will win the 2025 Virchow Prize, Professors Quarraisha, Abdool, Karim, and Zulfiqar Bhutta. A very warm welcome to you. Also, I would like to warmly welcome my esteemed colleagues from the Virchow Foundation, Professor Detlef Ganten and Professor Ole Petter Ottersen. Also, a warm welcome to you. Thank you very much for being with us. So what is this all about? The Virchow Prize was established in 2021 on the occasion of Rudolf Virchow's 200th birthday. And as you can see, we have here now also books that describe the origin, the history of the prize, but in particular also give more insight into Rudolf Virchow's work and contribution to this. It actually exemplifies the contributions he has to what is called health for all. So in that sense, you could say the prize embodies in the best possible sense the insight that medicine is fundamentally a social science, that health, equity, and social justice are very much linked. Or maybe to put it in a different way, as I could learn from Detlef Ganten once, education is the best vaccination. The theme we have, advancing women, maternal, newborn, and child health equity could not be more timely or urgent. In particular, where exactly these topics face enormous challenges, it's even more important to put emphasis on them and really to use the work of our laureates to also show them as a beacon for what is possible despite the challenges that we currently see. Professor Abdool Karim has been a pioneering force in HIV prevention research, particularly for women in South Africa. Her work has not only advanced our scientific understanding, but has fundamentally transformed how we approach community-centered health interventions. Professor Bhutta's lifelong dedication to maternal and child health across South Asia and East Africa has saved countless lives, turning rigorous research into policies and practices that reach the most vulnerable populations. So obviously we will hear much more about the great contributions of the two laureates, but it is great to see that all of this contributes a lot to the Sustainable Development Goals of the United Nations in various ways, on good health and well-being, on gender equality, on reducing inequalities. In particular, when we look at the time today, it is marked by an unprecedented level of uncertainty. So this is also what is visible, that is also documented in empirical ways. So we have uncertainty, we have complexity. And this also means, unfortunately, that in many parts of the world, we see setbacks on exactly the goals that two laureates have been praised for. But I would say we could also take it in a positive way to say that our laureates remind us that even in the most challenging circumstances, as the ones that we see right now, transformative change is possible when leadership is grounded in evidence, community engagement, and unwavering commitment to justice. And that is obviously something that is very important to us as ESMT. We were founded by 25 leading companies to develop responsible leaders who really make a difference, who take into account a very important view on business and society, and who link very closely theory and practice. So in that sense, what Leibniz once called the combination of theoria cum praxi. Since 2015, also in the context of the World Health Summit, we have worked together on the Young Physician Leaders Program. We do not have a program this year, but we have had the opportunity to train 240 young clinicians from more than 90 different countries. And some alumni are with us or with the World Health Summit today. And all of these leaders bring together the important links between healthcare, policy, academia, and civil society. So something that is very important to tackle the questions that we see here. So in that sense, we could also say what we see by our laureates is, of course, a very important part of research, without which action would be not possible. And at the same time, we see action that is driven by evidence and that really makes a big impact. In that sense, I'm very delighted to say that the Virchow Prize plays such an important role in an interconnected world, in a world in which uncertainty goes up, and in particular in which it contributes to improving the health situation for women and children, no matter where. And I think this is another very important part for the equality that we are here for. In that sense, again, a very warm welcome to ESMT, particularly warm welcome to our two laureates. Looking very much forward to hearing more about the great impact their work has, hearing more about what are the challenges that we currently need to tackle and how we can tackle them. And with this, again, looking very much forward to today, and as I said, hopefully to next year, because then we really have a tradition of having the Virchow lecture here at ESMT. With this, it gives me great delight and honor to hand over to Professor Detlef Ganten, the co-founder of the Virchow Foundation. Thank you very much.
Thank you, Jörg. We'll make every effort to make these Virchow lectures a tradition here in Berlin and around the world. Dear Virchow Prize laureates 2025, and dear ladies and gentlemen, dear guests, the Nobel Prize is being distributed since 1901 in the city of Stockholm by the Karolinska Institute. And the first Nobel Prize winner was Emil von Behring, coming from the Charité and developing the first vaccination against diphtheria. So, and there is another Nobel Prize, and that is the Nobel Prize for Peace, being distributed in Oslo, Norway. And another prize which kind of has the ambition of influencing the course of science is the Virchow Prize, which was established a short time ago in the year 2021, on the day of the 200th birthday of Rudolf Virchow, who was, of course, a famous physician here in Berlin, and he was born October 13, 1821, exactly the day, well, October 13, the day of the birthday of my wife. So you never forget. Rudolf Virchow and the Virchow Prize establishes is an independent prize awarding groundbreaking research, major innovations, and outstanding contributions of individuals and organizations with significant impact on the very broad field of health. And this, as we all know, and you know, is presented by the person of Rudolf Virchow in an exemplary way. Health, as was already mentioned, is influenced by the 17 Sustainable Development Goals of the United Nations. And more importantly, health itself influences each of these goals and serves as an entry factor, as a compass, and also as a measure of success, whether we achieve or not the 17 SDGs in a healthy nature and healthy lives on a healthy planet. That is our goal, and this is personalized by the Virchow Prize and by Rudolf Virchow as a person who showed that science has a social responsibility and at the same time has to show responsibility for the development of society as a whole. And the Virchow Prize laureates are considered ambassadors of this great and important goal and of this challenge. Professor Ole Pettersen, former president of Oslo University and of the Karolinska Institute, as you know, in Stockholm, he is the chair of the International Virchow Prize Committee, and I'm welcoming Ole Petter, he's also vice president of the Virchow Foundation, so he's closely associated with us. Thank you very much for all your activities, Ole Petter, and you will lead us through this ceremony today. Thank you very much.
Thank you, Detlef. And it's a great pleasure to have a foothold in Germany, in Berlin, and so many friends and colleagues here in this fantastic place here in Europe. And first of all, I would say that President Virchow, it's absolutely great that you're hosting here once again for this lecture. And my goodness, what a historic ground this is. So we had the pleasure of going through the building, and you know, this building is certainly a very important part of the history of Germany. So thank you for hosting us here. So Detlef Ganten said a few words about another important prize. Of course, Virchow Prize is a very important prize, but there are others, and he referred to the Nobel Prize. And, you know, talking about historic ground, this is also a historic moment. Perhaps you are aware of the fact that the Nobel Peace Prize for 2025 was announced 10 minutes ago. And of course, you're not interested in who got it. But it was awarded to Maria Corina Machado from Venezuela. And you know, I mentioned this because this prize, yes. And I think Detlef alluded to this. The Nobel Prize this year honors more or less exactly the same things as the Virchow Prize honors: justice, democracy, solidarity. I mean, we should be very well aware of the importance of these prizes because they serve as a signal to society that we have to be stewards of these very important values in these times that are challenging, turbulent, and times that really seem to work against us. But the signal that is being sent to the world at large with this prize, and also just by coincidence, by the Peace Prize, I mean, these signals are extremely important. And I'm so happy that the laureates that are with us today, they embody these values that we all should cling to, even if we are facing a very difficult time this particular year and this particular time period. So another historic thing, well, for the first time, the Virchow lectures will be published in Lancet. And they were published in Lancet 20 minutes ago, I think, or 30 minutes ago. So if you're interested in having these lectures, reading them carefully, you could consult the Lancet. And the title of the lecture that you have co-authored is very much the same topic that we will be discussing today: advancing women, maternal, newborn, and child health equity. As a physician myself, obviously, I'm very concerned by the fact that there are still underserved, underprivileged, disadvantaged populations on this globe. And I see it as, in the spirit of Rudolf Virchow, that we should attend to the needs of these populations, as you have done consistently throughout your career. Before going into the first lecture, I should honor also the prize committee that I think made a very good selection this year. I hope the laureates agree to this. And the prize committee is certainly global. It represents 5 different continents, And we are discussing the candidates from a truly global and interdisciplinary perspective, again in the spirit of Rudolf Virchow. So without further ado, I would invite Quarraisha, Abdool, Karim to the podium to give your lecture. We are certainly looking forward to this.
Thank you very much, Professor Ottersen. Professors Ottersen, Ganten, Rochelle, and Mr. Geeds, the members of the Virchow Prize Committee, other distinguished guests, friends, and colleagues. It's a real honor and privilege to be here this morning sharing this platform with a dear friend and colleague over many decades, Professor Bhutta. I want to use this opportunity to thank the Virchow Foundation for the honor of bestowing on me this laureate award, particularly as we also celebrate the 200th anniversary of Dr. Virchow. And we've heard well about who he was, what he represents, and to be a small reflection in service to humanity of what he is and stands for is an immense honor and a singular privilege. I also want to use this opportunity to acknowledge and recognize many people who've walked this journey for me to get here. My family, my husband Salim Abdul Karim, and I should say whenever I say we, it's the royal we, because we have walked this journey for over 37 years together as we have done our research in HIV/AIDS. For those of you who I hope we may see and who know already, is that we have our offices separated by a PA. And so we see each other 24/7. And I'm really pleased that he is here to be here. We've had wonderful mentors who've taught us the importance of science and social justice. Our choice of careers was no accident growing up in apartheid South Africa, being infectious diseases epidemiologists. There's rigorous and robust science with a social justice component, and that we deal with populations. So we are one world, one people, and we have to ensure sustainability of that for generations to come. I particularly want to thank all of the speakers for really presenting the context of the moment that we meet, of the convergence of many challenges. And it really demands of all of us to give our very best to ensure that we tackle these complex challenges. They don't have easy solutions, they know quick solutions. But science is forward-looking and it brings hope. And it is that hope as privileged members of society that in these times we have to hold high. And in these times also, it's the hope that we bring through science, science that unites, not divides, science that fosters peace, not wars and conflicts, and science that ensures we have a sustainable future for generations to come. So I'm going to talk about the 30-year journey of HIV prevention for women and how science plays a role, but it's how that science is undertaken. And you may think, wow, 30 years, and they still don't have solutions, but it reflects the complexity of the challenge of preventing HIV infection in young women. And I think we start with, I wanted to say a few words about the knowledge generation process. And in tackling these challenges, it's not one person who can solve it. It's not a few people. It needs partnerships and collaborations. Partnerships and collaborations that are based on trust and mutual respect. Partnerships and collaborations that bring synergy to what we do, that we can accomplish more together than what we can individually. But partnerships and collaborations that recognize that there are inequities and equalities and that work towards filling and closing those gaps, then we will be able to generate the knowledge that enables us to move beyond and start to see the light at the end of the tunnel. At CAPRISA, we are committed, the Center for the AIDS Program of Research in South Africa, co-founded with Slim and myself about 22 years ago. It is about focusing on local challenges. But I just wanted to spend a moment reflecting on the composition of the Center for the AIDS Program of Research in South Africa, and it is 80% women. And I don't mean women who are clinicians, it is women from leadership. We have 4 people in leadership. 3 out of the 4 are women, and it goes all the way down. In fact, our Department of Statistics is mainly women. There are only 2 departments where we have a bit of a challenge in terms of women leadership, and that's the team of drivers that we have, and the other is the IT department. But we have a reverse problem that most institutions have, in that we have more women than we have men, and sometimes we have muttering and mumbling. But I believe that it is this women-led organization that really has brought some new perspectives. And today, in dealing with complex challenges, it's an absolute luxury to exclude half the world's population. And I think we see what is possible when we create spaces, environments that enable women to reach their full potential, and for men and women to come together to address the complexities that we're dealing with. CAPRISA has 2 priority issues that it focuses on. It was at inception, and that we continue to 22 years later. The first is the high HIV incidence rates in young women, and the other is about the high mortality rates from HIV/TB co-infected patients. These are the 2 highest priority challenges in HIV treatment and prevention in sub-Saharan Africa, and 2 of the biggest obstacles in our trajectory to end AIDS as a public health threat that all UN member states committed to in 2016. Today, I'll be focusing on one of those priorities, which is preventing HIV in young women. So in 1988, Slim and I were master's students in the School of Public Health at Columbia University. Some of you in the room may not have been born, but if you went to Manhattan in 1988, what you saw was many young men sick and dying. If you went to Harlem, you would see women. And if you went to the Bronx, you would see injecting drug users. That was the face. It was absolutely devastating to see young people so sick. And we had only recently discovered HIV through Francois Barré-Sinosi's work, and Bob Gallo setting up the diagnostic test that enabled us to identify people living with HIV. And we had suddenly an opportunity for science to move forward and science to bring hope in an otherwise devastating situation. We were intrigued that in our lectures, our seminars, we're all dominated by this new phenomena, new challenge facing society. And we're learning about AIDS in East and Central and West Africa, but nothing in Southern Africa. So on our return in 1990, we decided to undertake one of the first population-based surveys. And this population-based survey told us something very interesting. The overall prevalence of HIV was less than 1%. But when we did the age and sex disaggregated analysis, we were shocked that up to age 10 to 14, there was very little HIV and no difference between boys and girls. But come to age 15 to 19, following the red line, what you see is a sudden rise in HIV infection. You look at boys 15 to 19, still HIV is rare. And then you follow that curve and you start to see infection in young men around age 20 to 24, peaking around 25 to 30 and continuing across the life cycle. And what you also see under the red curve is that there's more infection in women compared to men. This age-sex difference and our description of it was met with a lot of cynicism and skepticism. But subsequently, as the UNAIDS data started to gather and we started to see the picture of HIV, we see in sub-Saharan Africa, these red bars and blue bars showing this age-sex difference. And we're seeing that in several other countries. So this is quite unique. The world's attention was at that time on men who have sex with men, injecting drug use. There was very little attention or understanding or appreciation of this. So this was the epidemiological study. It took us many years later, when new technology became available, that we were able to, again, in population-based studies, understand through phylogenetic, through sequencing of the viruses and phylogenetic mapping, exactly how this was happening. And this was confirmation unequivocally that young women were getting infected from men 25 and above. So who were these men getting infected from? Women 25 and above. And this time, what you have is about a 1-year age difference. And if women over 25 and men over 25 only had sex with each other, we would see a very different trajectory in HIV in sub-Saharan Africa. But what some of the men also do is have relationships with women under 25. And these young women, a new cohort constantly coming in. So what we showed here was this particular cycle of transmission is what was sustaining the epidemic in these hyper-endemic epidemic settings, where if we can break the chain of transmission, prevent infection in young women in this 15 to 24-year age group, we could alter the epidemic trajectory. When we published this study in The Lancet, I'm glad Sabine is here, and that this lecture has just been released online in Lancet. The data was shared with UNAIDS because one of the underlying principles with which we work is work very closely with key decision makers, policy makers. And that year, the UNAIDS annual report was being prepared entitled Get on the Fast Track. They took our very complicated diagram. Scientists have a lot to learn about how to communicate in a more accessible manner with everyone. But the lovely simplification of that diagram. And importantly, the South African government, actually the National AIDS Council, was preparing its new strategic plan. And they also used this lovely diagram. They also changed it a little bit and went into infection pathways and made this the #1 priority in the South African National AIDS Plan about preventing HIV in young women and more around this life course approach and the importance of this transmission dynamics. So that was 1990, that was 2016. Let's look at what's going on today. Today, we've made a lot of progress. And with global solidarity, science, and activism coming together, we have universal access to treatment, and treatment not only transform AIDS to a chronic manageable condition, but it also prevents infection in the uninfected person, onward transmission of HIV. But TASP in itself, treatment as prevention, is not sufficient. And it's brought down the incidence rates in young women, but not sufficiently, as we see In this school-based study that we did, high school kids in one of the highest burden districts in the province of KwaZulu-Natal, where we come from, on the east coast of South Africa, 2 years into high school, you see this pattern persisting. You see data in men ranging under 15 to over 20 from 1 to 1.8%. When you look at women, you see already by age 16, double the more than 2.5 times more infection, 2.6%. And you see that steady doubling and increase in HIV infection every 2 years, where women over 24, 1 in 4 infected with HIV. By the time they get to age 30 in these communities, you're looking at 70% of the population. Why is this even important? It's important because we know about demographic transitions taking place globally, and that Africa is unique in that 65% of its population is under the age of 35. These young people are not just a dividend for Africa, it's a global dividend. We're also seeing epidemiological transitions, the infectious diseases, non-communicable diseases, etc., converging. But also, when young women get infected, they also have children about this age, 15 to 24, and if not treated and without interventions, they'll have transmission from infected mother to infant. But these young women, about 30% infected even before they turn 21, is about really decimating an important resource for society, for social and economic development. That's what's under threat. And we have to elevate the value we place on young women. And how do we do that? And how do we continue to do that? Okay, but now you know the importance of young women, high burden of HIV infection. What do we have in 1990? We have abstinence, behavior change, and male condoms. In a series of epidemiological studies, socio-epidemiological studies, in urban, in rural, peri-urban women, what we're hearing is they understand the risk that HIV poses, but they have very little agency to influence their partner, who's usually 8 to 7 years older, 7 to 8 years older than them, to negotiate safer sex. That they are monogamous, it's their partner putting them at risk. And remember, this time we're also looking in some communities where we had the migrant labor system, where men and women were separated for 11 months of the year, where men went to work on the mines or the cities and women left in rural areas. My a mentor and supervisor, Zina Stein from Columbia University, wrote this commentary in the American Journal of Public Health, making a call to action on the need for methods women can use. You can see problem, gap, how do we fill that gap? Slim and I spent, again, talking to women. We learned about some of their challenges on how to get themselves to stay uninfected. And then they came back to us and said, you're scientists and you're so smart, why don't you develop something we can use? And so began our journey in terms of trying to find a product, a technology to address a fundamentally social challenge of gender power disparities. We start with what's on the shelf, a licensed vaginal contraceptive, naloxone 9. What we learn is it causes harm. We want something that's safe and efficacious. And so we go on year after year, 18 years, very slowly, because there's no industry investment in products for women. We are in the NGO sector. We are in academic institutions, and we're trying to find products, and slowly we're moving. Maybe we need to change the pH in the general tract, buffer gel. Maybe we should change the charge so we can have repulsion, go to Pro 2000. And it used to be quite a challenge going into meetings. You know, the AIDS community activists, scientists, decision makers, we gather every year to reflect either regionally or internationally. And Slim and I would walk in, and then everyone, oh, here comes those experts at failure. So we got that moniker, and experts at failure. So in 2002, as we were writing our grant to NIH to establish CAPRISA, we were invited by a chief in one of the highest burden districts, about 1.5 hours from Durban. So when we get there, why are we called? Oh, you see, we are seeing about 15 to 20 funerals each day. What kind of a leader am I going to be if I have nobody to lead? Can you partner with me to find solutions? Can research add value in this community to prevent HIV infection and stop these deaths? So we go there and we start our engagement with the community, and we have a number of different discussions and meetings, and we learn about this new disease killing the young. And we get notification that we have this program award based on the 2 priorities we outlined from NIH. And we get there, that's one of our facilities being set up in Vulindlela in this. This is also a time when our second democratically elected president was questioning, does HIV cause AIDS? And here is this traditional leader so concerned about his community. So there we start. And what we find in screening young women to enroll them into a prevention trial, that we were screening out more women who were living with HIV than without. So PEPFAR is set up, the Presidential Emergency Program for AIDS Relief. We have the Global Fund for AIDS, TB, and malaria. And everyone's working towards how do we make treatment available. We come across this drug called tenofovir. But we use tenofovir for a whole lot of reasons that I've outlined there. But one thing we did was the woman said to us that we don't have sex every day. Can you give us a product that we can use when we have sex? And so we went back to the literature. We were inspired by HivNet 012, an intervention, 1 dose of nevirapine to the mother at onset of labor, 1 dose to the infant. And we had, what we saw there was a 41% reduction in transmission to the infant. And so we came up with this coetally defined strategy, 1 dose before sex, 1 dose after. We knew 2 doses, safety. As we shared the design, just as we started enrolling people, some of our peers actually challenged us, saying what we were doing was unethical, would set the field back. And Nature actually covered this. HIV trial doomed by design, say critics. So besides the moniker of experts at failure, we're also like messing up the entire field. Come 2010, at the International AIDS Conference in Vienna, we announced for the first time technology, the use of ARVs, preventing HIV infection in women. This was really the proof of concept of pre-exposure prophylaxis. That year, Science regarded this, the journal Science, one of the top 10 breakthroughs. We also saw this in top 2 in Lancet. I'm going to come back. And I wanted to highlight this particular picture that you see. As we were presenting the findings in Vienna, it was also being shared with participants. And that was the New York Times being in Vulindlela, capturing that moment as participants were receiving the news. Shortly thereafter, WHO convened a meeting, and then subsequently we had results from daily oral combinations of tenofovir with emtricitabine, and today 2017 guidelines, daily oral PrEP, an additional way to prevent HIV infection, and that's available in over 100 countries today. And but what about young women? So we're seeing good uptake in men who have sex with men. We're seeing good protection in discordant couples where the infected individual was being initiated on treatment. But in young women, we saw very low uptake rates and not persistent use. You've got to use these tablets every day. And so what we see is that oral PrEP being available in clinics, including in South Africa, including in this community, is not really having the impact that we were hoping to see in terms of PrEP and a method women can use. And so we had to move and think about how do we do this. This is where industry comes in. And suddenly we had Gilead Sciences, we had Merck, we had ViiV, all developing technologies, and we're seeing those products coming along. Most importantly, and what I want to highlight, is 6-monthly lenacapavir, an injection that opens the door for provider-initiated delivery of an intervention twice a year, making it very feasible in primary healthcare clinics and settings where access to healthcare facilities, access to care is fairly limited. And I'll show 100% protection. And what we have here is the possibility even of an annual injection in a couple years' time. And I think what we have to do is think very smartly. Will this be the game changer for young women, or will it just be one more thing that's included in a range of options at clinics, and we'll continue? And I wanted to just spend a few minutes on this issue, which is why 39%? And people said, oh, the women were not using the product. Well, what we saw was it was drug levels. And women need a higher, so already this virus discriminates against women. And now you have to have much higher drug levels for protection than you do if you don't. If you compared to men, if they take 3 out of the 7 tablets a week, they have protection. Women take 6 out of the 7. It's like they took 0 exposure to PrEP. And what we learned was inflammation is a risk factor, and the cause of the inflammation, we're still studying that. But a piece of good news is that we've moved from the lab to the clinics and watched the space. Maybe at some time I'll come back and tell you what the outcomes of our efforts are to try and restore the vaginal environment to a healthy one. In this process and all of the studies, our investments in young scientists has been key. This is really our treasure. I want to acknowledge many, many collaborators, the study teams, the participants from communities who do that, and to say that we have the science, we have the policy, but can we mobilize to actually make a difference in young women's lives? That is the question. What will each of us do to achieve that goal? Thank you very much.
So what a journey. Thank you very much for this lecture. Now it's time to go directly to Zulfiqar Bhutta, and you will be talking about advancing women, maternal, newborn, and child health equity, the same title as Quarraisha. So again, we are very happy that you even co-authored the paper in Lancet today. So looking forward to your lecture.
Thank you very much, Ole Ottersen. And thank you very much, the leadership and friends of the Virchow Foundation, the honorable leaders from this particular institution, for the opportunity to share some thoughts with you today. And like Quarraisha and Salim, who have been great friends for decades, and I'm greatly honored to share the platform with them, I too would like to acknowledge that although I'll present this as an individual, the work that I'm going to share with the work of hundreds of postgraduate students, trainees, and collaborators across continents. So let me start by underscoring the challenge that we face, and it's not a new challenge. The challenge of inequality or inequity, which represents an unfair inequality, has been with us for a very long period of time. And it was actually Rabindranath Tagore who made this poignant observation over 100 years ago. He said, fate had allowed humanity such a pitifully meager coverlet that in pulling it over one part of the world, another had to be left bare. And although he was reflecting on what he saw around him with one of the great famines of Bengal, this reality is starkly illustrated by what we see with the global inequities in maternal and child health and survival. So if you look at this map that we drew almost 20 years ago of where were 10 million children dying every year in the world, each one of these dots representing a cluster of around 10,000 deaths, you would see that these deaths are disproportionately clustered in Africa and South Asia. And that was one of the major reasons for highlighting what we needed to do differently to make a change in the Millennium Development Goal period with a strong focus on reducing maternal and child mortality. But these differences between countries are an oversimplification of what we are seeing in terms of differentials. So when I went back to my home country of Pakistan in 1985, one of the first things that we recognized was that we were not living in one country. We were actually living in 5 countries as reflected by this depiction of multidimensional poverty index across various districts. There were parts of the country where living standards were comparable to the West or high middle income countries, and others where living conditions were far worse. And this is reflected in how the health systems respond to some of these demographic challenges. So if you look at this map and contrast it with what's available, for example, for women's services, skilled birth attendants that's reflected in this particular graphic, you will find that the very parts of the country with the worst multidimensional poverty measures were also where there was almost no functional health systems in terms of care for women and newborn infants. And this is what got us going into addressing some of these social determinants of health at that time. And remember that around that time, the principles of inequity had not found their way into either the lexicon of global development or in the Millennium Development Goals. The whole concept of inequity in relation to maternal and childhood did not exist. We had no measures of that other than poverty. And poverty at that time was largely measured in the context of extreme poverty, per capita income, daily averages, how many people were making $1, $1.50 a day. But poverty has many dimensions, and I understood that by practical exposure in the field at a very early stage of my career when I went back. That we recognize at times poverty as lack of income or assets or purchasing power, whereas in the eyes of many people who live in those abject conditions of poverty, poverty is also about poverty of hope and poverty of imagination in terms of being able to break the shackles of what people find themselves in. Let me try and illustrate that by a quotation from someone I truly admired from South Asia, a saint who actually made this observation at a very early stage of her work. And she said, the greatest poverty is not about being hungry, homeless, or naked. It's the poverty of being unwanted, unloved, and uncared for, and with no hope that your want in life will change. Let me illustrate that again with an example from a very early exposure to this in the context of maternal child health, newborn health in Pakistan. This is a demographic health survey from 2006 with data collected 20 years ago, where you look at the traditional way of how we measure inequity in terms of the poorest to the richest and the gradient in terms of birth and preparedness. So we have traditionally how many people had access to facility births and how many people had access to antenatal care, measured here as access to tetanus toxoid vaccination as one marker. But we added 2 questions to the demographic health survey at that time. And those two questions were very simple. Is that how many of these husbands and wives had made preparations for childbirth in advance? Simple things. Had they even discussed where the birth would take place? Or had they even put some money aside as to preparing for births in facilities? And you will see that in the poorest quintiles, less than a third of people had even bothered to talk about where they would be born, just because there wasn't even the thought that their situation would change, that they could deliver in a facility instead in the hands of a traditional birth attendant. And this was reflected in one of the very first surveys I did in rural Sindh at that time, in just asking, where were these deaths taking place? So the quality of life in the average health system, even though the infrastructure existed at that time, was so poor at the basic level of village health units or basic health units, that even though health facilities existed in primary care settings, when the time came to make a selection in terms of where you would go with a sick mother or a sick newborn infant, people voted with their feet. They either tried to make their way up to the big city hospital about 4 hours away or 150 kilometers away, or they stayed where they were. And that's why at that time, in the distribution of mortality patterns, we found that almost half of all newborn deaths were taking place at home. About a third made their way up the health system, and about 5 to 10% died while seeking care en route. And this was fundamental, looking at strategies to change things, that you could do whatever you wanted in the referral tertiary hospitals where I was working, in the big traditional tertiary hospital of Karachi, but you wouldn't make any difference to the lives of many if you did not have programs that reached people who needed it most. So I can give a long lecture on what strategies can make a difference, but I will only focus on 3 things in the interest of time that people have tried and tried at scale, and we had the good fortune of working with in terms of how do you bridge this gap? How do you reach the poorest of the poor and make a difference across the spectrum of maternal, newborn, and child health? So the strategies that people have worked with in the development sector are things that can address poverty-related social determinants through safety nets, social safety nets, or through outreach programs that actually have health workers reach out, either embedded within the health system or from facilities in primary care settings. And the third are largely related to targeting. How do you measure, monitor, and target? Something that I've also had the good fortune of doing as the chair of the countdown to 2015 and then 2030. So on social determinants and on transfer programs to reach the poor, there are either unconditional cash transfers that you give to the poorest of the poor in terms of uplifting them, or you give conditional cash transfers, which are based around practices and behaviors that you could inculcate through those strategies. That's the general principle of doing so. Do they work? The jury is a bit divided on what works and what doesn't work. So let me share with you some of our recent work in Pakistan from probably one of the largest conditional cash transfer programs around maternal and newborn health outside of the JSY program in India. So this large program of conditional cash transfers, named after a former prime minister who envisioned this, is principally to give cash support, not to men, but to the women of the household, based on an objective measure of extreme poverty. This is one of the largest such programs in the world, which targets close to around 10 million families in Pakistan, and is based on this particular conditionality is based on receiving child immunizations, antenatal care, and also a nutrition supplement in pregnancy. So we had the great fortune for the last many years of evaluating this program in terms of its impact and in terms of its outcome. And this particular subset of the nutrition program has close to around 1.5 million individuals about 650,000 pregnant women. And to evaluate this, we had to set up a cohort, a longitudinal cohort that looked at this in terms of exposure and what really was happening to many of these families on the basis of receipt or non-receipt of the intervention. And lo and behold, you see clinical differences. Small, vulnerable newborn births are babies who are born small, either before their time or disproportionately small because they're growth retarded. And we see a hugely significant impact in terms of reduction in the births of babies who are small just because mothers are malnourished, because of this conditional intervention given at scale. And the important thing is, it's not just birth outcomes. This 20% reduction in stunting at 6 months of age, I can tell you because I lead the Global Exemplars projects in looking at stunting change, is one of the fastest rates of reduction of stunting observed anywhere through any large-scale public health intervention. And although we don't see a significant difference in newborn mortality, that's a function of the sample size. But you see the differences in terms of mortality outcomes also by virtue of this intervention. So that's what you can do by conditionality around reducing poverty. The other major program that I've been involved in, particularly around large-scale effectiveness evaluations, is really using community health workers, but not community health workers through the lens of service delivery only, but through the lens of participatory development, working with rural communities and instituting interventions that are also based on community engagement, participation, and sustainability. So I had the great fortune that when I started thinking about this way back in 1996, 97, the government had already introduced, again, giving credit to Benazir Bhutta, a program of female health workers called lady health workers, embedded within the villages, volunteers who worked with women around family planning and primary care. And this is the program that we decided to work with in rural Sindh in this large first cluster randomized trial of trying to see what could be done through 3 simple measures. The first important measure was to engage the gatekeepers, is to work with the men of those communities to make sure that they understood the value of their women working with women in terms of improving their want. And we never regretted that for a moment. The second was working with the community health workers, the lady health workers, in getting them to engage the communities through group sessions. So some of that was a bilateral transmission of information, and the other was just getting women to work with women. And you can see the illustration of some of that benefit through the eyes of participants of one of these sessions. So what do you see in this image in terms of who participates? So you see 3 generations represented here. You see the mother-in-laws who are very skeptical in terms of the messages they are coming. Quizzical expressions. You see the women who are actually not just listening, they're also talking to each other. We talk about diffusion of innovation, that's the best way to do that. And most importantly, you see the young adolescent girls who are not supposed to be there perhaps, but they're getting information in a way that they wouldn't otherwise. So what did we find in this groundbreaking cluster randomized trial at that time? Now there have been many. We saw a huge impact at a population level, and this 1.5 million population in this rural district, of about a 15% reduction in neonatal mortality. If you look at early neonatal mortality, that's a massive reduction. But we found something that I never expected. We found a reduction in stillbirths. And we had not put a single extra physician or obstetrician in that district. So when these data first came, I actually sent my team away. I said, go back and redo this because we haven't done anything. Why are you seeing an impact on stillbirths when we put no intervention in the hospitals per se? So we actually did go back. And they saw the pathway through which it could have happened. So one was, of course, an improvement in antenatal care at that population level in the intervention clusters. But the other, most importantly, was a vast improvement overall in facility births in that region. So from close to around 40% facility births, we went up to 60%. Now, this is almost 20 years ago. We went back several times since, after the end of that particular project, and we found that once people start going to a facility and have facility births in the hands of trained care providers, they don't ever go back to the traditional birth attendant. So that change has been sustained. Now, this was the basis, once we saw the impact of community-based and primary care programs for maternal and newborn infants, that we modeled this as part of the Every Newborn Action Plan about 10 years ago in 2014. And we demonstrated through this modeling exercise that it would make a huge difference depending upon where you were in high mortality populations, neonatal mortality rates more than 30, and also that these would make a difference depending upon what kind of intervention could be provided by the timing of interventions, per se, at birth and immediately after birth, both in domiciliary settings and in facility settings. And just hot off, about to go to the Lancet, are our first estimations of what impact today, when we have 1 million fewer newborn deaths every year, could you see by these strategies? And these modelings indicate that you would still see a 34% reduction in newborn mortality, even in this day and age, when so much has changed in terms of perinatal and newborn outcomes. The last thing I want to talk about is the importance of measuring and how the eye does not see what the mind does not know. And one thing that we learned over time was the importance of matching equity measurements with things that make programmatic and policy sense. So as my friends at Berkeley used to say, from Gavi, we know that 1/5 of all children are unimmunized. The challenge is that the 5th child who's unimmunized is not standing next to the 4th child. So targeting them requires a level of information that can only be possible if you actually measure inequity as part of your routine health systems work. And that brings me to the last set of projects that we've done over the last 15 years in trying to link child health with immunizations, and particularly in conflict and humanitarian settings, in settings which are very challenging because of insecurity. So one of these large projects where we looked at, in the context of polio eradication, routine immunizations, was to look at such a context in the complex scenario of urban and peri-urban Karachi, a population of 25 million. And we recognized straight away that of the proportion who were unimmunized, these are children who have no immunization whatsoever because the families refuse or they don't have health services. They're largely clustered in certain geographies. And to reach them, you need tailor-made interventions that will reach those populations at large. And the big question that I was asked at that time when I was designing this big implementation project was, you sure you can reach them? What difference will it make? And I kept saying that those differentials are possible to breach. So if you look at the data at baseline in terms of gaps, this is now, imagine, in peri-urban, urban squatter settlements. So you see huge gaps even within the poor, amongst the poorest of the poor and the relatively rich. So look at the gaps in terms of unimmunized children, partially immunized, and fully immunized children at baseline. And then 2 years later, after an implementation which was done by the government people and by community approaches, you see how much difference you can make in terms of reducing inequities in a humanitarian and conflict setting. So let me close, ladies and gentlemen, by saying you can make a difference to these egregious inequities which are totally unfair and manageable. They're manageable within our means. But to do that, you really recognize that the answers lie very much within the contextual realities of the systems that you're working in. It is really not necessary to transplant things into those geographies because you can work with the communities to find solutions to the barriers that they recognize are barriers. But they require 3 principles that one should have. One is that you have to recognize that bridging those gaps is a fundamental human right. Now, that is where we have the current challenge. Equity, I'm afraid, has become a four-letter word in many parts of the world. With the changes that we're seeing in the global landscape, there is very much this thinking that the poor have it as bad as they do because that's their want in life, and that this is principally their problem. And it isn't. In many instances, as we know from what happened during COVID also, they have the worst outcome because of systemic social differentials that disproportionately expose them to some of those risks. So the second important point here is that you have to do the right things. You have to have the knowledge of the right interventions. But more importantly, as Quarraisha was also saying, you have to learn to do it the right way. The implementation science around some of this is extremely important. And although the Nobel Committee may not recognize this, Ole Ottersen, but public health is one of the greatest benefits in science, and it does not have as yet a recognition in our quest to reward only discovery. But some of the greatest discoveries in the world have been around global health outreach and public health strategies to reach the poorest of the poor. So in this current scenario, our big challenge is one of loss of hope, of a sense of paralysis at this stage in the eyes and minds of men. And this is where we need to avoid complacency. And my sole purpose in sharing some of these thoughts with you today is because it's complacency that is our biggest enemy right now. I'm so honored that I'm here at the Virchow Award ceremonies and this lecture because he was the founder in many ways of the principles of social medicine. And I want to close with a quotation that is not often cited from him, which I think is a very clear enunciation of how we need to lead the change. And what Rudolf Virchow said, I don't quite know which year he said this in, was that it's the curse of humanity that it learns to tolerate even the most horrible situations by habituation, tolerance, considering that as the new normal, and that it forgets the most shameful happening in the daily shame of events. And it can hardly understand when individuals aim to destroy this infamy. So what he said such a long time ago holds absolutely true even today. And I hope that some of you will help us bring about that change. Thank you very much for your attention.
Thank you very much. Thank you. We talked about complacency. There is another quote I think is so appropriate in these times where we have to be vocal and talk about inequities. And that is, silence is violence. That's also very true. Now it's the time for a panel discussion. And it's my honor to invite again our laureates to the scene. Please take a place here. And we have two additional panel members. Rana, please take a seat. And Mariam Jashi and Rana Hajjeh. Please. So please.
I think
Well, it doesn't really matter.
following the order.
Okay.
Free seating. Free seating, as they say.
They actually reversed the
I think we all can agree that these lectures were absolutely the point, absolutely timely. And I think we are all reconfirmed in our conviction that the Virchow Prize is more important than ever. Because, as was pointed out, it sends a very clear signal to the not only the scientific community, but the political community, the world at large, that we are dealing with so important challenges now that have to be handled in a way that is not just covered, as you said, by the Nobel Prize in Physiology or Medicine, because that prize, if I may, is still very much focused on the biomedical side of science. So I think we could say that this prize fills a gap because it points to the very essentiality of public health and global health. So I think that we should give the new panelists the privilege here. Is that okay for the laureates?
Yes, absolutely.
And I think we should start with you, Rana. And we had a short discussion prior to the meeting today. And I think we should go straight into one of the challenges that I think even Rudolf Virchow saw. And that is, how do we secure a translation from science to better governance and to better public health in a time where science is not always respected, to put it this way? That was an understatement. So, Rana, you have been working in so many different leadership positions, WHO, also in CDC for more than 20 years. And what we see in some parts of the world, not only in the US, mind you, is that science is not really respected to the same extent as we have seen in history. It's the most difficult question I can possibly think of. I'm sorry. How could you ensure, or how could we ensure, that politics will remain evidence-based and that there will be, as we have seen today, this possibility of translating science and research into better health, and not least better governance for health? I'm sorry to ask this very difficult question.
Yeah, no, thank you. Thank you very much. Actually, first, I mean, it's really a pleasure to be here. And I have to say, it's quite a hard act to follow these amazing, two very inspiring presentations. So thank you very much. And I had prepared some notes, but actually after listening to you, I threw them all away. You know, I think, as I mentioned one time to a colleague while at WHO, because I was being a bit accused that I'm not too political. And what I said is, and that was actually at the time of the first Trump administration. I'm coming directly from Atlanta, so excuse me, because I've been witnessing very painfully what's happening to public health and to science in the US. But at the time, I told my colleague, I said, look, I fully understand the political realities, but I will never let politics trump public health. Sorry for the play on words, but that's exactly where we are right now. Politics is trumping public health and science, I would say. I think, you know, there's a huge need to have a complete mind shift also when we address policies and strategies for public health, because the focus for a long time has been on maybe health as a kind of an individual sector. So I think, and it's very telling that we are here celebrating the Virchow Prize, because Virchow was a leader in this whole, and I think he was quite ahead of his time. He wasn't just a physician and the public health professional. He was a politician. He fully understood why it's important to be engaged in politics and why policies are important. So I think, you know, that multi-sectorality is really important. We cannot address science separately from what else is going on in the world. As we have seen, the interaction of science, I mean, we keep talking about the social determinants of health. It's beyond just social determinants of health. There are many other determinants of health. I mean, right now it's the political determinants, the environmental determinants. And actually, I was just flipping through the book when I received it from Detlef before the meeting. And just I happened to see this quote from Virchow: "Freedom, education, and prosperity are the most important prerequisites for health." Freedom, that's a huge word right now. Education, and I think someone mentioned at the beginning, he said that education is like for vaccination, is like needed, and prosperity, which is development. So I think it is really critical for us as health professionals, especially in the world of public health, not to keep our blinders on. We're not going to ever achieve our impact. The goal of all of this is to maximize the impact of these amazing interventions that scientists are developing all over the world. And we're not going to achieve this impact if we keep our blinders on and only invite to our meetings similar health scientists who believe in the same thing, basically preaching to the choir. I think what we need is to engage ministers of education, ministers of environment, and very, very importantly, ministers of finance. And that's what we had done before, because without finance, the policies do not have teeth. And what we are witnessing right now in the world is a significant cut in health financing. So I think it's very, very important to ensure that multi-sectoral approach and that, of course, community engagement is really critical. But beyond just community engagement, country engagement.
Yeah.
Maybe the only silver lining I see right now with all these, very painful cuts in health financing globally is that countries, and I've seen it all over Africa and South Asia, countries are starting to take more ownership. Country engagement is critical. And I think us, especially when UN agencies, we focus on, we do the intervention, we prove it works, we engage the communities, but then what happens after we leave? Who's going to ensure that these interventions will continue to be fully owned, sustained in the long term? Who's going to ensure the primary health care centers will continue to have the quality healthcare professionals who will engage the communities and bring them on? So that's really my key message.
Thank you. And I think your key message is a fantastic introduction to the next panelist and to a question to you, Mariam, because you have certainly been also in many leadership roles in global health, and you are CEO of the Global Sepsis Alliance. So you have seen some of these challenges close range. So Rana, you touched upon, not only touched upon, but you described one of the elephants in the room, because there are many elephants in the room, and one is financing and what should we say, the economic basis for country ownership and country contribution. When I'm traveling Africa, I must say that when I learn that several African countries pay more to honor the debts than they invest in health and even in education, the total investments in health and education is less than they have to pay for death. How could we possibly, I know you have been working on these financial issues. How could we, in real life, ensure that Rana gets her ambition in place, that there will be more ownership, that the countries can build, let's say, holistic healthcare system, so that what happens in the communities really can be translated into better health for these populations?
Thank you, Ole. It's an immense honor to join the panel and to have the opportunity of sharing some of the experiences. And before we start any discussions about financing, I think that we have to all agree on the basic principle, the fundamental principle, that the most powerful and sustainable way of funding health is through domestic budgetary allocations. As the former minister and the senator, member of parliament of Georgia, we have seen that even with low resource settings, if there is a political will, you can allocate sufficient resources for ensuring basic universal health coverage package, specifically for women, maternal, neonatal, and child health. In Georgia's case, it was $150 per capita, but we were able to secure that every citizen was covered by basic primary emergency in hospital and other healthcare packages. Once the country defines its own strategy and financial capacities, then we start what 20 years ago was called the Paris Declaration principles of aligning and harmonizing international aid around the domestic resources. And innovative financing, of course, is the third new dimension that brings in catalytic, not the funding that can replace national commitment, but catalytic funding to bridge the gap, similar to Global Fund when the unmet needs were covered, or similar to UNITAID when HIV, TB, and malaria resources were secured. Working with the governments is feasible for prioritizing, especially maternal, neonatal, and child health, especially considering the fact that for decades, MNCH indicators were not only the Millennium and Sustainable Development Goal indicators, but some of the core indexes in the human development and country socioeconomic development status. Again, coming back to like Georgia's case, universal health coverage was embedded in political manifesto. Based on the election cycles, there are opportunities where you can specifically catalyze domestic government's commitment to health, and especially today when we see the diminishing multilateralism in global health and diminishing resources, the role and sustainable investments through domestic funding is increasingly important for funding health.
Thank you very much. One aspect here, I remember a lecture given by Bitin Gitai a while ago, and he said that, well, it will take quite a lot of time until African nations can finance healthcare, but they certainly can finance health. I mean, alluding to the importance of what you are doing, prevention. I mean, that's also an issue. And perhaps we could ask our laureates, how could we, and I've seen this close range working with healthcare systems in several countries, how do we see to it that political decision makers understand the importance of doing exactly what you have been doing over such a long time, to really not just look at what happens in the tertiary healthcare system, but that they see the value of prevention and community-based healthcare. It's in one of the regions that I've been working in the Nordic countries, just a small part of the budget was invested in prevention, even though we know how important it is. How could we switch this mindset? Should we start with you, Quarraisha?
And I think that, just agreeing with the previous speakers about political leadership and investments and so on, one of the things Zulfi mentioned was about measurement. And I think when we look at the global burden of disease, which is often used to prioritize and allocate funds, it is fundamentally driven by morbidity and mortality patterns. So if we want to do preventive and promotive health, that's one of the sort of paradigm shifts that we need to be making, particularly as, knowledge generation has evolved from serendipity to lots of molecules to really now where we're looking at AI and precision medicine, precision health. I think we can get to early preventive approaches and the opportunity. But two other points that I wanted to make. The one is that as much as there's political will and commitment and leadership, that there are many constituencies that politicians serve. And so when they make a decision, it has to satisfy many people. And sometimes the evidence is not sufficiently compelling for that to go forth. So I think I'm a little bit more circumspect about how much evidence can influence policy. The second is that I think we learn over and over again, particularly where we're dealing with extreme inequities and inequalities, that when we're generating the knowledge to solve that problem, we need to bring the potential beneficiaries in very early in the process. And so we're finding solutions. So in HIV, we have this, one of our principles is to work with communities, not on or for. And I think we've seen repeatedly this nexus between activism and science and how powerful that is and how scientists can be advocates. But this idea of communities owning, being part of co-knowledge creation, co-owning that knowledge being created, I think has a better possibility that when you got something that works, the uptake will be high and use will be. So the same with preventive and promotive health. If we start that process, we take everyone on that journey, adoption is probably better facilitated.
And time is running out. I'm very sorry, but you, Sophie, you should also be in a position where you can dwell on this particular issue.
So let me, in the interest of time, say I have pivoted some of my work over the last 7-8 years to a study of exemplars. Now, these exemplars are positive outliers or positive deviance examples of how countries have made progress despite the restrictions that you have of socioeconomic growth, development challenges, sometimes, contextual challenges of environment, climate change, conflict, and other challenges. Now, what you consistently find in these exemplar studies of real-life examples of how countries have progressed, whether it's with a very difficult challenge of childhood stunting or maternal health and anemia or newborn survival maternal health, is that they consistently invested in addressing social determinants of health. We remember that half of all change that you see in even things like childhood stunting or mortality are from investments that my colleagues mentioned are essential to change environment, education, women's empowerment, things that do not necessarily fall under the remit of the ministries of health, but are absolutely important from a political dimension of where leadership stands. So that's one of the first principles, that you have to invest in the health and well-being of communities through the lens of investing in some of the systemic issues that keep them behind. And that includes the issues that I've mentioned. The second is really from the very get-go, targeting on reducing disparities as a political imperative and not to depend upon the principle of trickle-down economics. That you lift the entire ship and somehow or the other, magically the poorest of the poor will benefit. That can happen, but it takes a very long period of time, and it does not reduce disparities in the same way as if deliberate efforts to reach the poorest of the poor. Many countries in Africa, many countries in Asia have made tremendous progress over the last several decades because their political leadership made it a principle that they would reach the poorest of the poor and reduce those gaps. One final point, Ole Petter, that I would say is you should look upon the Millennium Development Goals as a resounding success. We were able to, and I say the royal we, global community, policymakers, at a time when the world was not as divided, were able to reduce maternal mortality and child mortality at a rate which is fastest in the history of mankind. From 10 million deaths that I showed you in that infographic, when that figure first came up in our meeting in Bellagio, we were shocked because we didn't really know that the figures were that high. There were some approximations at the time, and some of us, looked at this when the Millennium Goal targets were coined, but nobody had a clear idea that really 10 million deaths. By the end of the MDGs in 2015, when we counted, there were just barely above 6 million deaths. Now, that rate of change could not have happened without the world coming together, the political will, and also the tools and technologies that allowed those changes to happen. There are representatives from Gavi here. Sonia is not here, unfortunately. It will come tonight. But vaccinating all children of the world, irrespective of where they are and who they are, one of the greatest public health goods and tools that we could make to bring about that change. And that was on the principles of global equity and justice that is so fundamental to change.
The final comment here, but we should have had a question, and a Q&A section also now, but we are running late, and I think we have to close very soon. But on this final note of yours, I think we should ponder introducing a new determinant for health, not only social, political, but ideological. Because when they talk about vaccines and the resistance in some quarters against vaccines, we are beyond politics, we are into ideologies. So that, I think, is what we are facing as a huge problem today, the ideological determinants of health. Virchow would have been pleased to take part in this discussion, but we have the laureates and we have the panelists, and I hope that this discussion has been of value to all of you. And I'm really sorry that there is no space left for questions. Thank you very much to the laureates, and thank you to the panel.
Thank you. Thank you.
Great, thank you.